So in this particular slide, I'm going to talk about some of the treatments that a patient may undergo who's got cancer, right? So remember, there's surgeries that can happen. Remember, they can get chemo, they can get radiation, just a whole bunch of different things can happen for this patient. So in regards to this slide, it's basically saying that many cancers or many malignancies exhibit a dose-treated response to chemotherapy. So increasing the dose of chemotherapy increases the number of malignant cells being destroyed. So the more chemo you give, ideally the more malignant cells you're going to be able to destroy, right? So that makes sense. The dose of chemotherapy that is delivered is limited by the toxicity. And the major toxicity that can happen from chemotherapy is myelosuppression. So that's your bone marrow, and you know what your bone marrow does at this point. So if you're suppressing your bone marrow, that is definitely not a good thing, right? So keep that in mind. So the use of bone marrow or stem cells from either the client or the donor allows the bone marrow to be rescued from the toxic effects of chemotherapy, allowing for higher doses of chemotherapy to be administered. So we're going to unpack this in the next couple of slides so it makes better sense. So BMT, which is bone marrow transplantation, is an accepted treatment to stimulate a non-functioning marrow or to replace the marrow. All right. So we already know that, in some cases the cancer itself destroys the bone marrow. In some cases it's the treatment itself that the patient is getting, like chemo, radiation, etc. All of those things are causing bone marrow suppression. So we know that we may need a bone marrow transplant. So a patient may end up getting an intravenous infusion of bone marrow cells from the donor to the patient. So this happens a lot, especially if the bone marrow is non-functioning. For sure, then they're going to need to get a bone marrow transplant from somebody else, from a donor, right? So this is done a lot in leukemic patients, which we discussed under another slide there. So this would be good for this patient. So if their bone marrow was non-functioning, then we'd give them a fresh transplant of bone marrow. Okay. The donor's healthy immune system is able to recognize the patient's malignancy as foreign and kill any remaining tumor cells. So they can also use the bone marrow to specifically kill off any remaining tumor cells. And if that's going on, they would call that a graft versus tumor effect. All right. So remember, I think I talked about this, but it was a different, I think it was graft versus host that I discussed under blood transfusions in a different slide. So know that in some cases they're giving the patient the bone marrow because their bone marrow is depleted, it's dead, it's not even working. So that's just a boring bone marrow transplant. Or in some cases they're giving the bone marrow, specifically a healthy one, so that it can basically get into the patient's body and kill off any remaining malignant cells. Specifically, that's the purpose of it. And if that's why they're specifically given it, which I would think is pretty much all the time, then that would be considered a graft versus tumor effect. So it's the graft, which is a donor's bone marrow, right? That's the graft, because now you're getting that from outside, and then you're transplanting that into the patient, and then it has the effect that you want on the tumor cells itself. So don't make this complicated. Just know that you can have a bone marrow transplantation, specifically if the bone marrow is not working, they need to replace it. It's given as an IV infusion from a donor to a patient, and the donor's healthy immune system is able to recognize the patient's malignancy as foreign, and it kills off any remaining tumor cells. So if that last bullet is described for you, then you know that that's known as a graft versus tumor effect. All right. So they can also do what is known as a peripheral blood stem cell transplantation, PBSCT. So this is a method of removing circulating stem cells from the peripheral blood through apheresis. Apheresis methods, and returning these cells to the patient after the patient has had a really high dose of intensive chemotherapy. Supposedly, they say that PBSCT has fewer side effects, has shorter hospitalizations, and decreased cost compared to BMT, which is a bone marrow transplant. So you can use the patient's own stem cells, then that would be considered autologous, or you can use a donor's stem cells, and that could be called allogenic. Or you could use stem cells from an identical twin, and that would be known as syngeneic. So what is happening with in this process here? So peripheral blood stem cells by themselves, they are immature cells, immature. They make white blood cells, they make red blood cells, and they make platelets. All right. So the white blood cells are fighting off infection, the red blood cells are carrying oxygen, your platelets are helping with bleeding, right? So we already discussed the fact that the cancer treatment in particular destroys stem cells, right? It destroys your bone marrow. So we don't like that. That's a bad thing. So in a PBSCT transplant, what they are going to do is they are going to collect the stem cells, right? So they're going to collect the stem cells before a patient has chemotherapy treatment. They're going to collect, so what they're going to do is they're going to collect your blood, right? That whole process, the machine they're using is known as apheresis, and you've come across apheresis types of methods when we talked about things like plasmapheresis. So in that case, under plasmapheresis, we're specifically looking at the plasma. That's what we were concerned about. That's what we're cleaning out when we're talking about things like I think it was under myasthenia gravis. Right, but here we're collecting the blood, right? We have this machine, this process known as apheresis, and we're specifically taking out these stem cells. All right, and we're collecting that, putting it aside, and then we're returning the blood back to the patient, and then your patient is going to get the a huge dose of chemotherapy, whatever it is, a huge dose of chemotherapy. You already know what chemotherapy is doing. It's literally destroying the patient's bone marrow. So the patient's immune system is basically really, really compromised. And then after the patient has had the chemotherapy, they are going to give the patient back the stem cells that they had collected. Okay? So you've collected blood before patient gets chemo, you've taken out your stem cells, you've given the patient back their blood, you've given the patient chemotherapy, and now we're going to give the patient the stem cells back, because what we already said that the stem cells do what? They do a lot of good things, right? They're making more white blood cells, they're making red blood cells, they're making platelets, so they're making new blood cells that the patient needs, because otherwise if they're getting chemo, the stem cells are getting depleted, they're getting destroyed. So that's the whole idea behind this. So don't make it crazy for yourself. So this is a picture that's basically trying to describe all of that. You have the cancer patient here, right? You know they're scheduled to get chemo, right? So what you're going to do is you're going to harvest your stem cells, all the bone marrow, whatever you need. You're going to treat the stem cells or bone marrow with agents that destroy any malignant cells that may be in that in the stem cells, right? Because you remember the patient did have cancer. So we take out what we need for right now. We treat it as much as we can without harming our normal cells. And then when we're ready, after the patient has had the chemo, they've had their remaining bone marrow and cancer cells are basically destroyed, right, which is what we're trying to prevent, then we're going to give them the intravenous injection of the purified stem cells. And when they come back when you give them this new freshly treated stuff, then that stuff is basically going to produce new blood cells, which is what we wanted. All right. So main takeaway is just before a patient gets the treatment, we're going to harvest, take all of this out, make it as clean as we possibly can, and then give it back to the patient after they've had treatment. So we have several types of targeted therapies here. And specifically, we're talking about the biologic response modifiers. We know that chemo and radiation usually attacks the proliferating cells directly. And with this one, with the chemo and radiation, you're killing off both your healthy cells and your malignant cells, right? So that's why we don't like the systemic effects that can happen because of that treatment. So to kind of counteract all of that, they came up with the targeted therapies, and supposedly they're minimizing the negative effects of the healthy tissues by disrupting specific cancer cell functions. So they're trying to target particular cancer cells. So with the biologic response modifiers, the main takeaway is that they are trying to stop or destroy the malignant growth. So they alter the immunologic response between the tumor and the cancer patient. The main thing I just want you to remember is that they're basically trying to rev up your immune response, like really make your immune response as strong as they possibly can, so that you can fight off the horrible manifestations that are going on in your body from the cancer. So just all the different parts of the immune system. So whether it's the colony stimulating factor, whether it's interleukins, like all of that just gets really, really activated within your immune system, so that you can be really, really strong. And main side effects are stimulation of the inflammatory process, because that's what they're doing. And flu-like symptoms that can happen in the patients. But once again, some of them are better than others, and some of them are much stronger and can create worse things. So this is your nursing process here. So the following common problems should be considered. So you have things like infection, bleeding, pain, malnutrition, fatigue, and psychosocial issues. And I think all of that makes sense for you at this point. So you're just making sure that you're monitoring all of this. You're always using Maslow, right, as your as the process for you to make sure that you're meeting all your patients' needs. So here, so what do you think? Are these problems in priority order? So all the stuff we just looked at, what do you think might be the priority for your patient? And so the point is, you just want to make sure that you're using Maslow, right? You're not going to worry about self-actualization if the patient is, let's say, bleeding to death, as an example, right? You'll probably, things like bleeding, pain, infection, malnutrition would probably be some of the things that you'd worry about first, before you worry about fatigue necessarily, or psychosocial issues. All right. So you're looking at a very focused assessment. So bleeding, would rule the world in terms of, making sure the patient is not bleeding, making sure they're not going into shock, things like that. Temperature, infection, all of that. You're going to be monitoring pain. In cancer patients is always like a priority, because they're always in pain, right? And then you're also monitoring the nutritional status there, right? So making sure you're doing your labs, looking at your serum albumin levels, all of that. Looking at the coping skills of the patient, significant other, all of that. You're making sure that you're looking at everything. All right. And so you have a slide here with some ranges and some numbers. You want to make sure you're looking in your book and we're using those particular values and ranges. All right, so same thing. All right, so patients may experience a variety of secondary problems, things like infection, bleeding, pain, nutritional problems, fatigue, and stress. So that's definitely true. Some potential nursing diagnoses like risk for injury related to bleeding tendencies, risk for infection, chronic pain, nutrition being imbalanced, fatigue related to myelosuppression, risk for ineffective coping, anticipatory grieving, and body image disturbances. So all of these, if you read them, should kind of resonate with you. You're doing your patient teaching, as always, and depending on how advanced your cancer is, maybe body image is a factor, right? And depending on where the cancer is, because if it's something like, I don't know, facial cancer from the sun, or throat cancer, right? Then now they have radiation, and maybe they end up needing a trach or something like that, right? So you just have to really make sure you've done your assessment and you see what your patient needs. What is the most dangerous adverse effect of antineoplastic therapy? And so we have things like kidney failure and longer-term bone marrow suppression. What does neutropenic precautions mean? So we've talked about this under neutropenia. So all of this should be making sense to you. All right. So this is just is targeted therapy. It minimizes the negative effects on healthy tissues by disrupting specific cancer cell functions. So that's what it does.